Welcome to The Explainer. Today we are jumping into the really complex world of pediatric heart conditions. We're going to try to translate some of this intricate medical stuff into a story that's clear and makes sense, from the very first moments of a child's life and all the way beyond. So let's start with a number. 8 out of every 1,000 infants. That's how many are born with a significant congenital heart defect. Just think about that for a second. It's actually the most common structural problem a baby can be born with, which really shows you why this topic is so incredibly important. All right, so here's our game plan. We're going to start with the big picture, then look at the wild changes that happen right at birth. We'll get into how doctors spot problems, how they classify them, what happens when issues pop up later in life, and finally, we'll cover the amazing progress that's been made in treatment. Okay, let's dive right in. The easiest way to think about a child's cardiovascular system is to imagine it's like the plumbing and electrical wiring in a house. For everything to work, that initial design and construction has to be just about perfect. You see, most heart problems in kids are what we call congenital. You can think of these as design flaws in the original blueprints, errors in construction that are there from the very start. And then there's a much smaller group of problems that are acquired. These are more like wear and tear issues, things that pop up after birth, maybe because of an infection or something similar. Now let's get to what is honestly one of the most dramatic moments in all of human biology. It's this massive switch that happens in the circulatory system the instant a baby takes its very first breath. It is a full-on system reboot. See, in the womb, a baby's lungs are basically offline. They're not breathing air. So the blood cleverly bypasses them using these special shortcuts. But the second that baby is born and takes a breath, bam, those shortcuts have to slam shut, rerouting all the blood through the now functioning lungs to get oxygen. It's a transition that has absolutely zero room for error. And here's where things can get really tricky. For some babies, the ones with those design flaws we mentioned, that little fetal shortcut is actually a lifeline. So when it starts to close naturally, which is totally normal for most newborns, it can trigger a life-threatening emergency for these little ones. So the big question is, how does anyone know if the plumbing isn't working the way it's supposed to? Well, let's look at the clues and the warning signs that doctors are trained to hunt for. Okay, so one of the most common clues is a heart murmur. You might be surprised to hear that about 30% of all kids have one at some point, but that raises a really important question. How does a doctor tell the difference between a totally harmless wish of blood flow and a sign that there's a real problem underneath? To figure it out, doctors basically become detectives. An innocent murmur, it's usually soft, it happens when the heart is pumping, and the child seems perfectly fine otherwise. But a pathological murmur, well, that one comes with red flags. It might be really loud, it could happen when the heart is relaxing, or it might be paired with other signs of distress. And it's not just about murmurs. Doctors are on high alert for 3 other critical signs. For an infant, heart failure can look like getting sweaty and out of breath just from trying to eat. Then there's cyanosis. That's a bluish color, especially on the tongue, which is a telltale sign of low oxygen. And finally, shock, which is a sudden collapse, a true medical emergency. Okay, so we've been talking about all these complex design flaws, but there's actually a pretty simple way to start sorting them out. Most of these congenital heart defects can be put into one of 2 big buckets. They either make a baby primarily breathless, or they make them blue. And it all comes down to the direction of the leak, or shunt, in the heart's plumbing. If you have a left or right shunt, like a hole between chambers, it sends extra oxygen-rich blood flooding back into the lungs. That overload makes the baby breathless. But if the leak goes the other way, a right to left shunt, then blue, oxygen-poor blood bypasses the lungs completely and gets sent out to the body. And that's what makes a baby blue. To really get what makes a baby blue, let's put one classic example under the microscope. Tetralogy of Fallot is the most common reason for this condition, what used to be called blue baby syndrome, and it's a perfect example of a really complex plumbing problem. It's called tetralogy because it has 4 distinct features all happening at once. There's a hole between the main pumping chambers, the body's main artery is sitting right over that hole, there's a narrowed path to the lungs, and finally, the heart muscle on the right side gets all thick from working so hard. All 4 of those things together create the perfect storm to send blue blood out to the body. Now here's another critical blue condition called transposition of the great arteries, or TGA. And this one is a fundamental wiring error. The 2 main pipes leaving the heart are literally switched. It creates two completely separate circuits of blood flow that never mix. This is a condition that's just not compatible with life, unless there's some other hole or that fetal duct is still open, allowing the blood to mix. So we've focused a lot on problems that are there from day one, but not all heart issues are. Let's take a quick look at acquired diseases, those maintenance issues that can show up later in childhood. In high-income countries, the one that really stands out is Kawasaki disease. It's a kind of vasculitis, which means it's an inflammation of the blood vessels. And the big danger here is that it can damage the coronary arteries, the very vessels that feed blood to the heart muscle itself. Now, the tricky thing about Kawasaki is there isn't a single test for it, so diagnosis depends on this very specific checklist of signs. It all starts with a fever that just won't go away, plus other signs like a rash or really red eyes. Getting treatment fast with something called immunoglobulin is absolutely crucial to prevent that long-term heart damage. So, after hearing about all these different issues, you're probably asking, what can we actually do about them? Well, the answer is a lot. The progress in this field has been nothing short of remarkable. The modern toolkit is just incredible. We have imaging that can map out the heart's plumbing in stunning detail. We have procedures that can fix holes using a tiny catheter, no open heart surgery required. And for the most complicated repairs, the surgical techniques have gotten so good that things that were once impossible are now done routinely, and the outcomes are just worlds better. And this quote right here just sums it all up perfectly. The whole game has changed. The ability to find problems before birth, to see them more clearly, and to fix them more safely has completely transformed the future for these kids. The big story today isn't just about surviving. It's about thriving. It's about turning a story of a diagnosis into a story of incredible lifelong potential.